Pearls on integrating newer AD treatments. Hello everyone, and thank you for tuning in. In this episode, we have the pleasure of speaking to Dr. Lauren Schachner, who will share some additional clinical pearls about the diagnosis and treatment of pediatric atopic dermatitis. Dr. Schachner, how do we make sure that we correctly diagnose atopic dermatitis? What are some clinical pearls you can share with our audience?
Correct diagnosis of atopic dermatitis is often a clinical diagnosis because of its classic appearance, but all medical conditions are best diagnosed by starting with the history. So what's the patient's history and what's the family history? We have to remember that atopic dermatitis is part of a trilogy. It's a disorder of the skin, in which there's often also a disorder of the respiratory system, like allergic rhinitis, sinusitis, reactive airway diseases, and disorders of the gastrointestinal mucosa, where people can have food intolerance or milk intolerance. So we start with the history. If the diagnosis is in doubt, there are a couple of additional questions that often help. Let's say it's a 3-year-old and we're not sure. So did the baby, or now in this case, this toddler, have a history of seborrheic dermatitis or a cradle cap earlier on? Does the baby have a history of severe reaction to bites, like mosquito bite, papilla, urticaria? Was there a history of a tough-to-resolve diapidermatitis? Was there formula intolerance, sensitive skin? So there's a number of key questions such as those that help nail the diagnosis. Plus, we want to know the same type of information about siblings, for example, whether it's siblings who had similar issues. And that'll help us make the diagnosis of atopic dermatitis on those occasions when it's in doubt. You also asked about pearls. So I think a couple of really important pearls that I would have every specialist remember is that atopic dermatitis in infants and children is a disease of the whole family. Your patient may have the rash, but the whole family may be losing 1 to 2 hours of sleep a night if the child is moderate to severe. There is a large financial burden on the family, so remember, the families may be spending an average of $2,500 to $3,000 a year on an atopic child's care. Also, the atopic child does tend to suck a lot of the oxygen out of the air in the family. So how are the other kids doing? Are they getting inadequate attention? How is the marriage doing? Because there's a lot of anxiety and issues in the parents of atopic kids as well. So from a point of view of quick pearls, that's one. Another one is atopic dermatitis is complex. And we often tell families, all right, we're going to help your child. We're going to give them some topical care, perhaps a topical steroid or a topical calcineurin inhibitor, or maybe a phosphodiesterase inhibitor, and we're going to give some emollients. And your kid seems really itchy. We may give an antihistamine. There's a chance your child's a little infected, perhaps an antibiotic. Nobody can keep that straight. So if you're not giving a handout of direction to your patient, you're not going to get compliance. No handout equals no compliance. Lastly, a lot of us feel pretty good when we give a child appropriate therapy and they use it for 10 days and their rash greatly improves or goes away. But that's only half the job. The rest of the job is the maintenance of benefits. So the pearl is you have to have a plan for how you're going to get long-term benefit out of the initial medications you first prescribed that did the job. There probably is one more that we should add, and that is if your stable atopic patient is flaring, the first 3 things to think about is Staph aureus, and Staph aureus. Because Staph aureus, 95% of the time, will be the reason why a stable atopic starts having a moderate to severe exacerbation. So think of staph first, then you may want to think about herpes, tinea, drug sensitivity, topical care sensitivity, etc.
Now that dupilumab is approved for children with atopic dermatitis, what is its role and where would it fit into the Schachner ladder?
If you've used the Schachner ladder using the medications that I suggest for the severe and moderate severe child, and it's not working, then you have to start thinking about dupilumab, especially now that it's available down to 6 years of age. I would say I would certainly consider a patch test in case the child's having a contact to something, but while I'm planning the patch testing and before I start the dupilumab, I would be discussing dupilumab with the family. So it's right after patch testing for my moderate and severe atopic patients. It's come way up my therapeutic algorithm.
How do crisaborole and dupilumab fit into the long-term care for AD? For how long should they be used?
For crisaborole, it's now been approved down to 3 months of age, and there have been safety studies that go out, a year. I talked a little bit about the practitioner needing a maintenance plan. And one of the things I do after a atopic patient is cleared, if crisaborole has been part of the therapy or if a TCI has been part of the therapy, instead of stopping all therapy, I have the parents use that twice a week, usually Monday and Friday, to the areas of predilection, the areas where the parents know their kids always will start a new flare. And by doing so and using these long-term, it's been found that you can attenuate exacerbation markedly, with kids often going half a year to a year or more without a severe flare or the need for steroid or other rescue. So I think topical care like crisaborole really has a long-term, as is a TCI, a long-term potential benefit. And in my care, I'm using them for a year or more as a maintenance therapy. As far as dupilumab, there have been a number of studies also looking well out over a year. And while you can see a lot of studies that talk about starting dupilumab and maintaining dupilumab, I will challenge you to find too many studies about what happens when you stop dupilumab, because many clinicians and patients are so gratified with the results that they don't want to tempt fate. So while, we're talking not about a label experience, but we're talking about real world, I think dupilumab in many hands is now being used for several years at a time.